Good afternoon and rather good morning or good afternoon, ladies and gentlemen. And thank you, Dr. Lalit, for having me here again. And thank you, Dr. Talwar, and thank you, Dr. Mallika, for putting it right across that treatment is required. You cannot stop treatment. So these are the conditions where you need to keep treating these patients again and again. Topic that I'm going to talk about, that whether biosimilars have filled the gap. I'll proceed further. Before that, these are my disclosures. I do have disclosures to various biosimilar companies across the globe. We have been trying to understand biosimilars since last 4 to 5 years in terms of various aspects like, how do you switch, whether switching between biosimilars have any significance, or what kind of phase 3 trials that biosimilars go through, and why there is negative perception about them in the beginning. So this is our contribution in the form of various publications, and I would definitely like to highlight our group across the globe who have been part of all these work that we published in the recent past. So the question is gap, whether biosimilars, they fill the gap. So first question is gap, means what are we talking about here in terms of the gap? So if you really look at Dr. Talwar, what he said in his talk, I give a ranibizumab. He didn't mention that I give Avastin, right? So we have come to a stage where we started talking about that I give ranibizumab. That means ranibizumab has become your primary drug of choice now, which was not there in the past, probably if you talk about 5 years before. So the gap which was there between Avastin and Lucentis, the pricing is approximately 3 to 4 times. So this was the gap which India was looking for, because we are in a different kind of financial system. Our patients are in a different kind of financial system. So this was the big gap which was created and which needed to be filled in. Need. Now let's come to the need, that why you have that gap and from where that gap is created. If you really look at the data, although as a country, we are not really data-driven country, our statistics are not that great compared to West, but still, if you have a nutshell analysis of the diseases where you need biosimilars, or rather anti-VEGF injections, so you have approximately 0.8% of total adult population more than 30 years suffering from RVO, and then you have diabetic population of approximately 7 crore, and out of them 7% have diabetic macular edema, and approximately 16% of Indian population more than 50 years with a prevalence rate of 3.4%, you have a population of more than 1 crore. More than 1 crore patients, they require anti-VEGF injection, and this is not a one-time injection. So you need 1 crore anti-VEGF injections every month. Look at the disease burden. Rather than disease burden, look at the financial burden that our patients have to go through. Even I can talk about, means I'm a middle class person. Even if something goes wrong with my parents, it is difficult to afford this therapy for my parents as well, unless we have filled that gap. So that is what has happened in India. If you really look at the statistics, what is happening because of non-affordability? You have a huge group of patients who are lost to follow-up. Our average injection rate is approximately 3. And our previous speakers have very well highlighted that that does not work. Unless we keep treating these patients, I think all of us are retina specialists, and we have seen patients who have been on therapy for a very long time, they have enjoyed vision, they have enjoyed their activities for really, really long time. So now, Dr. Lalit asked me, you speak about whether that gap is being filled up or not. So I lead an international retina biosimilar study group called InterBios Group, where we are trying to understand whether this gap is being filled in India or over the entire globe, different countries. There are few biosimilar powerhouses like South Korea, India, and some countries in Europe as well. So this was an essential survey by the Vitreoretinal Society of India in collaboration with InterBios Group, where we try to understand that what kind of gap was there and what is happening now. Before I proceed further, to the findings of this, I have two questions to this wise audience. How many of you have heard about biosimilars? If I can have raise of hands. Thank you. And how many of you have used in your entire practice at some point of time any biosimilar? So probably this is around 50 to 60%. So now let's go to our survey. So this was essentially focused on the retina specialists. So what has happened in the past, in last few years, is that gap of ranibizumab, which is the only biosimilar that you have available now, it has a proportion of 75% usage in majority of practices. And then what happened to the innovator ranibizumab, which is Lucentis? It has shrunk down till less than 25%. Prime reason, financial. It decreases the cost to the patient. Now, all the retina specialists, they agree that it has definitely made therapy affordable, and they would surely like to use this therapy in coming future as well. So, the gap is being filled by biosimilars for sure. And as Dr. Talwar said, I was in some other session yesterday also, now people are talking about, I start my treatment with ranibizumab. And I think I would definitely give credit to biosimilar ranibizumab for the same. Otherwise, still, if these molecules wouldn't been there, Lucentis pricing would have been staying there. We would have been having this gap. We would have been using Avastin more and more. We would be seeing this financial gap, and we would have been having all these dropouts. So this has made a major difference. Now the question is this just India? Now biosimilar means, I'm not sure how many of us are aware of, you have biosimilar ranibizumab across the globe now. Europe has it, UK has it. So there are two major molecules which are available. One is Cimerli, one is from Biogen. Cimerli was the first molecule that has received interchangeability approval by the FDA, which was first time in the history of FDA that any molecule has received interchangeability approval without any additional trial. Let me explain you what interchangeability means. That means patient comes to you. In US system works in a different way. There is, a lot of time doctor does not have that say. Your insurance company defines it. They decide that what this patient has to get. You just write ranibizumab, and then insurance allows, it can immediately at the pharmacy level, it can be substituted. So that is what the interchangeability is. So that is happening. I was in academy last 3 years before when Cimerli was being launched and Biogen product was being launched, where a lot of our colleagues were talking about that we do not see any future of biosimilars in America. Reason behind, because they are quite confident with Avastin because they have compounding pharmacy, robust compounding pharmacies, they can fractionate well. They have no issues with any kind of legality in terms of off-label use, and means they never had troubles with that. But what happened? I was in URetina last year. What has happened in America, you look at the developed world. In the last 2 years, biosimilar ranibizumab has crossed the usage of Lucentis in United States of America as well. So it is not only us. We are financially compromised in a different way. Our patients are financially compromised, but countries like America, Europe, they are financially compromised in a different way, where insurance drives to have cheaper drugs so that they can put that money somewhere else in the patient care. So this is the paper that we recently published, because whenever I speak about biosimilars, a lot of questions come in that can I use this one, can I use this one, this is from where. So in a nutshell, in India as of now, in use, you have 3 manufacturers who really manufacture these drugs. Razumab from Intas Pharmaceutical, with the highest real-world data, they market themselves. So Razumab is from Intas. Now another drug, Ranizorel, which came after Razumab, it is manufactured by Reliance, and it is marketed by Cipla as well under the name of Vizumab. Renice, product of Lupin, they manufacture it. It is marketed by Sun Pharma with the name of Osiva. So just remember that original manufacturers and the marketer. Another molecule which came recently had trouble in the between. Patient means product is withdrawn from Engine Biosciences. Optimab, that is a product of Alchem, marketed by different companies, Ipca and Mankind. So now I already explained you the differential. Like what happens, whenever biosimilar comes in, you have different kind of negative perception going on around there. And as a clinician, as a person from scientific community, this is our responsibility that we convey the right information. This was a paper which was recently published in Ophthalmology Retina, Biosimilar Paradox, how anti-VEGF endothelial growth factor biosimilars could increase patient cost and healthcare cost. Such a deviated, such a biased title. By title, you can assess that maybe anti-VEGF might be increasing cost in America. But this was essentially hypothetical. In case on-label bevacizumab approves in America, then Avastin would be banned, and then the cost will increase. We had a strong rebuttal against this, that this should not be conveyed. This causes negative perception to people. So I strongly believe that many lives can become better. They are getting better since we have biosimilars on our practice. And as you have more and more molecules coming in, it is giving a pricing pressure to everybody. Other biosimilar guy, originator guy. So ultimate, at the bottom of the pyramid, beneficiary is your patients. That's what you wanted. So thank you so very much for having me here.